The rash healed months ago, and everyone keeps pointing that out. Your skin looks almost normal now, and yet you sleep in a recliner because the weight of a bedsheet across that one band of skin is intolerable. A shirt seam, the draft from a car window, and underneath the burning, jolts, electric and unannounced, while you sit perfectly still. My name is Gurpreet Padda. I have treated this for 20 years. That is not skin that failed to heal. It is a nerve cell body a virus attacked and did not fully survive. The damage is not where the rash was. It is upstream, beside your spinal cord. Two failures put you in that recliner. The first is time. The randomized evidence for nerve blocks in shingles lives in the first weeks after the rash. You were told to wait, that this fades in most people. The antivirals were the right call, and inside 72 hours they were started correctly. The failure was that nobody set a date to see you again, and that pain severe enough to predict post-herpetic neuralgia was treated as something to outlast. By referral, the window the trials studied had closed. The second failure runs the other way. Burning in both feet from diabetes or chemotherapy gets offered a single nerve root block. A block treats one root, one side, one strip of skin. A polyneuropathy is failing every long axon in both legs at once. Offered without an anatomic reason, you are not being treated. You are being scheduled. The varicella zoster virus you met as a child never left. It withdrew into the dorsal root ganglia beside your spinal cord and stayed there for decades. When cell-mediated immunity thins with age or illness, it reactivates in one ganglion and travels down the axons to the skin. That is why the rash was a band, the skin territory of one ganglion. Human autopsy studies show hemorrhagic ganglionitis, bleeding inside the ganglion, and the loss of large myelinated fibers. Animal models then show surviving nociceptors upregulating sodium channels and firing ectopically, inferred to drive dorsal horn sensitization. Be precise, that inference is animal work. It explains the spontaneous burning, damaged neurons firing on their own, and the allodynia, where the light touch of fabric reads as injury. The leading explanation is that losing large myelinated fibers degrades the circuitry separating touch from damage. Leading explanation, not proven mechanism, and not the only one. Some patients have the opposite picture, skin numb and painful at once. A history of shingles is a clue, not a conclusion. Radicular pain from a disc is also dermatomal, but it is provoked by position and loading, and often brings a diminished reflex. Intercostal neuralgia after a rib fracture follows the same band from another cause. Length-dependent polyneuropathy is symmetric, stocking-shaped, and does not respect a single band. And zoster can reactivate without any rash, considered when no skin history exists. Resolution is tactile, a brush and a cold probe, mapping whether the abnormal zone honors a dermatomal border or ignores it. We test strength and reflexes and image only when the picture stops behaving like one dermatome. So who is this for? Two groups. First, acute or subacute shingles pain confined to one dermatome, still within weeks of the rash, where the randomized data lives and the clock is still running. Second, single-level radicular pain where symptoms, examination, and imaging name the same root. There the block is a diagnostic instrument, confirming the pain generator before a larger decision. The trials I cite were run in shingles, not radiculopathy. Outside those two groups, this is not your procedure, and I will say so in the room. The target is the nerve root emerging from the foramen, immediately adjacent to the ganglion the virus damaged. A selective nerve root block places a small volume outside the foramen on the root itself. A transforaminal injection drives medication through the foramen into the epidural space, spreading above and below. Different spread, different risk, different literature. What I am describing is the extraforaminal selective version. Hold that, because in a moment I will tell you no randomized trial studied it. In the neck, ultrasound shows me soft tissue fluoroscopy cannot. The anterior and posterior tubercles, the root in the trough between them. Doppler runs the intended path before the needle moves because the vertebral artery lives there. But be exact about Doppler. It helps me avoid a vessel. It cannot tell me my needle tip has entered one. Only contrast, injected under live fluoroscopy, does that. And the cervical level carries the highest rate of unrecognized intravascular injection anywhere in the spine. So ultrasound maps the anatomy and fluoroscopy confirms the injectate. At every level, contrast outlining the root sleeve before a single drop of non-particulate steroid. Rathmel and colleagues published a consensus in anesthesiology in 2015 with the FDA Safe Use Initiative because rare catastrophic neurologic injury has occurred. And the corticosteroid is not approved for injection around a nerve root. That off-label use is accepted and you deserve to hear it said. Kim and colleagues in the Korean Journal of Pain in 2017 meta-analyzed 9 randomized trials. Blocks applied within 3 weeks of rash onset shortened zoster-related pain and lowered the incidence of post-herpetic neuralgia at 3, 6, and 12 months. Incidence, not severity once you have it. If you are already living with it, that study describes a door you have walked past. The benefit came from paravertebral and from continuous or repeated epidural blocks. Stellate ganglion block did not deliver it, and neither did a single epidural injection. None of those 9 trials tested a fluoroscopically guided transforaminal nerve root block. Zheng and colleagues in pain practice in 2019 ran a placebo-controlled trial of ultrasound-guided cervical root block in acute cervical shingles. It cut the 30-day burden of illness. Their conclusion was that reducing post-herpetic neuralgia might be feasible. Feasible is their word, and I will not upgrade it to proven. Now, the limits. Anesthetic relief lasts hours. Steroid benefit is weeks to a few months. Repeat blocks for long-standing post-herpetic neuralgia have no trial support. The serious risks are vascular and neurologic, injection into an artery, nerve injury, epidural bleeding, a punctured lung at cervical and thoracic levels. The common ones are days of high blood sugar and a brief dip in adrenal function. The full list is on screen and in writing. Where metabolic disease is degrading nerve repair, we address glycemic control because a nerve healing in hyperglycemia works against you. Here is the thing that does not sell a procedure. The strongest evidence in this disease is not about blocks. In the pooled ZOE50 and ZOE70 trial data reported in the New England Journal of Medicine in 2016, the recombinant zoster vaccine cut post-herpetic neuralgia by roughly 89% in adults 70 and older. Nothing I do with a needle comes near that number. If you are over 50 and have not had that vaccine, that conversation matters more than this one, and most of all, for those who have not had shingles yet. What I am about to describe is a composite, a picture assembled from many patients with this condition, not one person's chart. Someone arrives 5 weeks after a thoracic rash healed, a burning band across the left ribs, clothing intolerable, sleep only upright. 5 weeks sits past the window where the data was generated. They were told proceeding was reasonable, not proven. An extraforaminal block was performed under live imaging with contrast, non-particulate steroid, anticoagulation held per plan. The first 2 days were worse, a post-injection flare, and glucose climbed for a week. By the second week, the allodynia eased enough to tolerate a shirt and lie flat, the first real sleep in 2 months. A neuropathic medication was titrated over 6 weeks, with the daytime dullness that costs, and desensitization added, brushing skin that hates touch. A second block a month later gave less. That was a judgment call, and I will name it as one because nothing supports repeating a block in established post-herpetic neuralgia. We stopped. There was no third. A diminishing response is information. At 6 months, the pain was a fraction of where it started, not absent. Now the part I am obligated to say. I cannot tell you how much was the block, how much the medication and desensitization, and how much was 6 months passing. Post-herpetic neuralgia improves on its own in many people, and no honest account of one course separates those threads. If a rash has healed and the pain has not, the clock matters, and waiting is not a neutral act. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Ask to see the contrast before the steroid. If something in this changed how you understand your own pain, that was the point. Bring us your imaging, your history, and your questions. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Everything in this video is education, not medical advice. Ask for the diagnosis before you accept the procedure.